crucial to the Equally Well conversation. How do we connect the dots between mental health services and general practice? We've got two people who are doing that for you. Simone McCallum is a GP passionate about advocating for equitable, holistic care for people living with mental illness. All hail the GPs that recognise that and make the time to achieve that. She's established the Embedded GP service within Eastern Health's mental health services. Now, where's that? Melbourne. Oh, my city. To improve the health and wellbeing of mental health consumers, in part by helping to reduce barriers to accessing holistic care, but she'll tell you more about that. Regina is leading a research project in this embedded GP service. She's a clinical nurse consultant at Hamilton Centre, Eastern Health Victoria, a nurse leader and a researcher brings experience from China, Denmark and Australia to really focus on bridging this gap. So I love that. What a duo you will be. Welcome.
Hi everyone. I'm so nervous, I always am, and I know I shouldn't be, but I just feel like if I announce that, then maybe it'll make it better. Okay. So I'd like to start by acknowledging and paying respect to the traditional custodians of this land, and also to express my gratitude for the care of the land over eons, and for now sharing it with so many of us, because we really have the most magnificent country to live in. I'm also thankful for the people with lived experience of mental illness and their families and carers, because your extraordinary courage and resilience in the face of massive adversity inspires me every day to strive to provide the most excellent care possible. We have a disclosure that we received funding from the Trophy Grant, which is translating research outcomes into the primary health interface. And also I just wanted to say it's such a privilege to be presenting at this conference. I've been reflecting that all the people who are here and who are involved in this collaborative or organisation are people that are here because they care really deeply about people living with mental illness. So it's a special circle to be a part of, and we all want to do all that we can to make things better. And we all also have really deeply personal reasons for being involved in this and doing the things that we do. So there's stories that sit behind what everyone's doing. And I have also been thinking about what Russell said when I came to my first Equally Well conference, was that we do what we can, where we can, when we can, or maybe that's slightly the wrong way around. But it makes me think about a good few years ago when I was... I've been a mental health GP for a long time, and at some stage I still do really get overwhelmed at times with all of what I see with my patients. They really struggle with a whole lot of things, and it does put a burden on the practitioner as well. You feel overwhelmed, you want to do so much to help everyone and fix everything, or at least I do, I think we all do. And so I remember expressing this to my then psychiatrist, who said to me, Simone, you can't fix everybody, you can't do everything for everyone all the time. You can only help some of the people some of the time. So I guess this is an acknowledgement that this program that I'm setting up now, so for the last 3.5 years, we've been establishing this embedded GP service. While I'm aware of sort of the broad problems that people face, the work that I'm doing is helping a small collection of people who have real vulnerability and are really struggling. So that's what I'd like to talk about today. And the easiest way for me to explain this is really to start by telling a bit of a story about how this all started. So I'd been working in Outer East Melbourne for many years as a mental health GP. And in 2020, partly sort of out of frustration with the mental health system and also out of increasing curiosity about psychiatry, I thought that I might retrain in psychiatry. So I made this bold move and left general practice and went to work as a psychiatry HMO, so a junior doctor in the local mental health service, and thought, yep, let's give this a go. So what I discovered was that learning about psychiatry is truly fascinating, and I would have loved to have become a psychiatrist, but the main thing that I saw were a tremendous number of people, patients in mental health services, in desperate need of holistic primary health care. So that's where, where was I going to... See, I've reworked this in my mind and I haven't put things in the right place. Can I go backwards if I go forward now? So this is forward. Just leave it here for the moment. So at this point, I just wanted to talk about what I see in terms of this drive to get equity in healthcare. And I think I've seen before the equality and equity poster quite a few times, but in my mind, I had this vision that actually what my patients are going through is they're in that third reality thing, or I had this vision that they were sort of like being dragged down off the pedestal and people were pushing them off and I was there kind of trying to prop them up and lift them up. So, and I think that a lot of the patients that are really struggling are the ones where they're like this little guy in the ditch. You know, the adversity has been stacked against them from before they were born with intergenerational trauma, multiple adverse childhood experiences, and by the time they get to be seeing me, there's so much going on, and I think to myself, how can I fix all of this? As a single GP in the community, I found that very overwhelming, but in mental health services, working as part of a team, it's a bit of a different story. So now, can I go back a slide, please? Or do I just press the red arrow? Thank you. Oh, this is magic. So going back to the story, as I worked through the various aspects of the service as an experienced GP in a different environment with a GP lens, all I could see were all of the things that needed fixing and all of the ways that having a GP may be able to help make things better for the patients within our service. There were lots of moments where I felt like being a GP in the service was really helpful for my patients, but there was one moment that I kind of remember quite clearly. I was doing weekend on-calls on the inpatient units, and I did morning ward rounds for the patients in the intensive care area, and there was a woman who was really distressed, and she was telling me unhappily about all of the things that you psychiatrists do. And after a while, I just said to her, I'm so sorry, I'm not a psychiatrist, I'm a GP. She said, oh, thank God for that. And she came out and she lifted up her nightie and showed me this really terrible rash all over her groin. And it was pretty clear that she'd been living with this burden of this painful rash in her genital area and hadn't even been able to sort of say, this is what's going on for me. So we went through a treatment plan, sorted out some creams, worked through everything. And she seemed to settle a lot just from having that one single issue addressed. So at that point, I really thought, this is a big thing. So at the end of 12 months, I had to, as a junior psychiatry doctor, I had to make a decision whether to pursue psychiatry or to return to general practice. And if I could have done both, I would have, but I'm not Superwoman, as much as I'd like to be. Ultimately, I felt that I could not let go of my capacity to treat the whole person. I wanted to always be able to be the person that if somebody came and told me about their vaginal discharge or their problems with their bumhole or their constipation, that I would be the one who would be able to say, let's talk about this and I can examine you. You can't do that as a psychiatrist. I didn't want to let go of that. And I realised that in my heart, I'm really a GP, and it was such a lovely thing because I thought, I'm so very sure now that I've followed the right career path. So I felt very strongly that the best way that I can help patients with severe mental illness was to remain as a GP and to provide physical health care in the context of their psychiatric illness within our mental health service. and to make it as easy as possible for our patients to access a GP. So trying to remove those barriers to care. And I was also quite mystified that mental health services have massive multidisciplinary teams, but they don't have any GPs on the team generally. So I spoke with our then really visionary leadership team about my ideas to have a GP on the team, and they were able to make this happen because there was some uplift funding from the Mental Health Royal Commission. So that's how this role was created, and since then I've been working to develop this service. So that was 3.5 years ago, and 6 months later we got 2 more amazing GPs on the team. And I should say that, not all GPs love doing mental health. That's okay. The ones that do it really beautifully. And so that's what we've got, and there are lots of other GPs who also love doing mental health. But we're a very specific group of people who really are very passionate about caring for patients with mental illness. So why is our service unique? I know there's a few services in Australia with GPs attached, but I think this service is different. We are embedded, fixed firmly and deeply in our surrounding teams like little tumours. We're a truly valued part of the team, and we participate in all of the team activities that help determine patient care. We are co-located within the community mental health clinics, and we work alongside the case managers and psychiatrists and the multidisciplinary team. So we're right there, and we provide... a key point is that we're salaried staff. So we're not limited by MBS item number billings, so we provide our patients with free care. What does our role look like? Between the three GPs, we cover all case-managed clients in community and rehabilitation streams, and we specifically target the most vulnerable patients who have no GP or poor engagement with their GP, and those patients who are at highest risk of physical health problems. We see people in the clinics, we do outreach visits, we see them alone or with their case managers or support workers or family. We sometimes do just a one-off consult, sometimes we do longer-term management, we do secondary consults with other staff or community members, so we're supporting other staff to provide holistic care. We provide support and education to all staff about physical health and holistic care. We liaise with specialists, emergency departments, community organisations, and try and develop lots of connections, all with the intent of improving patient care. We join in the clinical reviews and discuss cases in that context and share ideas with the teams about ways that they might be able to help from a general practice perspective. We attend handovers. We have planned appointments, but if we're available and something comes up, then we'll do urgent reviews, and sometimes we'll just pop in during a case manager appointment to try and build a rapport with somebody who's really struggling to engage. We provide patient-centred holistic care and help our patients understand that this service is about helping them to address their own concerns and not feel like this is one more thing that we're doing to them. This is about asking people what their concerns are and trying to support them to access the things that they want and need that will help them to feel better. So generally I'll go in and introduce myself, explain the role in the clinic, and just ask, how can I help? What do you want to do? How can I help you? And over time, there's also a shift in focus within our service to capacity building amongst staff so that everyone can take steps to support patients to improve their physical health. So we're having kind of like a culture shift where the whole organisation is bringing wellbeing into everyone's sphere, and it's becoming everybody's business to make sure that physical health is improved for all of our patients. And when I tell people about the work that I do, everyone says that's such a no-brainer. But as we keep on discussing throughout the conference, we need evidence to continue to strive for the best possible practice all the time. So part of my role has also been to do research, and I'd really love to be able to say that we have all this wonderful data, like we saw this morning from South Australia. You know, if I could have pulled data about saying things like, well, we've reduced emergency presentations and we have reduced morbidity and mortality, but the truth is we have within mental health services, we have a very old, clunky data system, not even like an electronic medical record. We don't have GP software, and so everything needs to be kind of manually extracted. So I'm sorry, I have no such data. But one of the projects that we are doing is this beautiful qualitative research, which is exploring the clinician's experience of caring for patients with mental illness. The trophy grant that we got has enabled us to have a professional external interviewer as part of our project, and that hopefully makes the research more less biased and more robust. And research has been such a huge learning curve for me because it's just like learning a whole nother language, I think. So that's been a big thing. But fortunately, I have the wonderful Regina on my team, along with a bunch of other people. But Regina's has such a good handle on qualitative research and how to go about it. So she's going to talk a little bit about where we're at with all of that. Thank you.
Thank you, Dr. Simone, and that was really beautiful. Good day, everyone. My name is Regina Tsai. I am a clinical nurse consultant working at Hamilton Centre Eastern Health, which is a statewide centre that we provide specialist service for people with dual diagnosis of mental illness and substance use disorders.
Sorry, I didn't advance that.
That's okay. All good. So a little bit about me. So I was born and raised in a small town in China, and as some of you might know, mental health is still hugely stigmatized there, unfortunately, because people don't want to talk about it, and some of them, they choose not to talk about it. So that motivates me to talk about it more and having my voice in different conferences. So my passion towards this integrated care and particularly embedding the general practice within the community mental health services comes from witnessing so many firsthand the significant physical health side effects and issues experienced by my clients. So when I was working alongside with Dr. Simone as a mental health case manager in community, so many those issues, they go unrecognized and untreated and even picked up far too late. And from this 2 days conference, we know there are so many shocking statistics and morbidity and mortality gap that is still very heartbreaking as a lived experience carer. So I want to share a personal moment that kind of pushed me towards this research work. So I still remember that powerless and helpless feeling when a client told me about their serious physical health concern. And because we have very limited physical health resources within the organization, all I could say is go to see your GP, even when I knew, how hard that was in the reality. So that moment stayed with me for 3 years and pushed me towards this research. And from there, I began to take a more serious look at the physical health needs of my mental consumers and became deeply interested in the integrated care models. So even when I changed positions and changed teams, like throughout the last 2-3 years, this project still holds a very special place in my heart. And I want to acknowledge a great thanks to the Equally Well framework and our local committee led by senior nurse Harry Singh. And with all this support, and we were able to carry out this project with Dr. Simone's great passion and compassion, as you can hear in her speech. So I want to talk a little bit about the dry stuff. So this research model is known as the reverse integration model, where instead of we are trying to make the GP clinics more mental health capable, we are bringing the GP directly into the mental health services. And the benefits of that is that mental health services cannot ignore any physical health problems that picked up and make it more one-stop shop instead of the wrong door, we are sorry. So although it is relatively new in research in Australia, there are some really great international evidence, particularly the ones from USA and UK, are showing a lot of strong evidence. So some of the benefits that it shows are improvements in access to primary care, of course, and reductions to avoidable ED presentations, and a better continuity. So they've achieved a higher screening rate and more consistent monitoring of chronic conditions, and in some cases, improvements of overall quality of life. However, integration isn't always that straightforward. Literature consistently highlighting some long-standing systematic level barriers, such as the separate funding mechanisms, the incompatible IT platforms, like Simone was saying, we wish we have, all the same information stored in one system, so we can, share them much more easily, and also that long silo and divide between mental health and physical health care. So being one of the first reverse integration programs in Australia, we are seeing similar challenges here. One very practical limitations was the clinical rooms. So sometimes, we are competing with the interview rooms that's completed by the mental health teams, and we need to borrow them, and there's no proper beds or curtains set up as such. But despite all these challenges, I want to still highlight that the benefits still outweigh the difficulties. And that's why growing this model requires very strong local evidence and, importantly, more multidisciplinary voices like nursing, allied health, medicine, psychiatry, peer workers, policymakers, because this is not something that one profession can solve alone. So a quick timeline of our research project so far. So we spent probably about 2 years just talking about it, and then really get it going is probably just this year. So the ethic approval was approved around May this year, and then we have our recruitment shortly occurred afterwards. And it is occurred in 3 phases, so we can, have some target promotion around disciplines, and then have organization-wide promotion, so we can ensure that everyone who wants to attend and fits the criteria won't be missed out. And then the interviews that commenced in June, and then we have already finished it in early September. And at the moment, we are working on the thematic analysis with a team, with monthly discussions to categorize those themes and findings as we agree on. So here, I just want to show you our flyers. So it's printed both digitally and as a paper form. And we have a wonderful research team, including 7 clinicians. Myself as a nurse, we have 3 GPs. So all the GPs that's involved in the program, they are helping us to promote the study. 1 lead psychiatrist and 2 mental health researchers of social worker and chiropractor background. So this multidisciplinary approach also been crucial in shaping our project so far. In total, as you can see, we have 36 participants signed up for the study, and we have a range of representations here. So we have registered nurses, enrolled nurses, occupational therapists, psychiatrists, psychiatry registrars, social workers, and team leaders. So this just want to show, it does provide a rich and comprehensive set of perspectives in our study. And in total, we have 19 professionals that was selected and included to complete the one-on-one interviews. And just want to quickly point out, although this qualitative research, we want to in-depth analyzing, how mental health clinicians are thinking about or viewing about this program, we also want to acknowledge that co-design has been an essential part, although the criteria didn't, include, but we have some initial co-design consultations with lived experience workers and the carer peer support, and together we identified the research priorities and safety considerations and ethical issues. And after we conduct some informal surveys with clients to test early ideas, that we decided to begin with the low-risk clinician perspectives. So this will help us, to create a safe and stable foundation for the first evaluation cycle. And in future phases, so we can include clients directly to have the research projects. I want to share some early findings. So first of all, our clinicians have consistently described that embedded and co-located GP surveys have been highly beneficial for them for holistic client care. And I'm very also glad to hear that many of them report also increased their own clinical confidence, like their knowledge has been increased about physical health, and they actually have a greater job satisfaction, which I didn't expect as much before the study. There are some practical suggestions also emerge, including expanding GP coverage across additional mental health sites, because at the moment it's only community, but if we can think about maybe acute, subacute, rehab in different settings. And also maybe expand the GP scope to do more training and education and potential vaccination clinics. That was one of the emerging themes. So looking ahead, our aim is to develop a structured annual evaluation tool, and we plan to embed ongoing consumer co-design so the model continue to reflect, the service users' needs. Thank you so much for listening.
Oh, there's a revolution in the making. Well, it's already being made. It's made. A question from Helen Piper. Is there a national register of mental health GPs?
No, thanks for that question. No, that's not that I'm aware of, but you might know, Michael. No, but no, I don't think there is, but it's a great idea, isn't it? I think that sort of thing happens more from word of mouth. People sort of get the idea that somebody is more of a mental health GP. I think that with community GPs though, the risk is that if you see only mental health, then it can lead to burnout because it is a lot to carry when that's the only thing you do. You sort of also need to see. You don't want to de-skill in the other areas as well. That's
a conversation that needs to be had within the community who want to do this as well, isn't it? How do you prevent burnout? How do you support each other? Yeah. From Josie, hi Simone and Regina, fantastic initiative. In regards to embedding the GP roles into the pre-existing multidisciplinary team, curious to know more about what strategies we use to embed this position into the team to foster interdisciplinary practice, inclusive of the consumers, e.g. particularly communications processes, care planning, etc. Josie from Nimai.
Sorry, I don't think I'm...
Yeah, sure. So that's a really good question. So initially, this program has been around for 3 years. So initially, I think we are raising the awareness among the team just by word of mouth. And our 3 GPs, they possess very valuable personal qualities of being very approachable. So I think being there, being co-located in morning meetings so everyone can see that you are there, and being in the office where mental health clinician sits, they can just bring a physical health question over without being silly, and then just ask about it and then discuss about the client in a very safe and confidential way. So I think that helps the program to raise the awareness and increase the communication very effectively. And then this research also helped raise the communication among the teams, because when I was promoting the study, surprisingly, some mental health clinicians never actually utilize it. But because of the research study, they become aware of it, and then they start becoming very interested in it. And we have allied health dietitians, and we have we have OOTs probably in the same organization. They just become aware of each other and start utilizing each one. Yeah.
Becoming aware of each other. Are there many men who specialise in mental health GP and nurse practitioner work?
Yeah, the 2 other GPs that are in the clinic are male, so...
Yeah, I was just interested to know.
It is interesting, and, they tend to get more of the men's health kind of stuff, whereas I get the women's health. Not that, we can't all do both, but it just sort of... And people feel more comfortable sometimes with one or the other.
Yeah, yeah, absolutely. Dave Peters giving the best questions. I don't mean to rave, but just sharing a lot in the course of giving a question. Sorry, Simone, I love that colleagues colleagues respond to your description of your work saying it's a no-brainer, but have any of these responders commented about why they haven't or can't also focus on physical health despite their no-brainer attitude?
I think that comment is not necessarily coming from colleagues. That's a general comment. So, but if you're asking about, are you asking about why GPs in the community don't focus on mental health?
Inpatient services.
Oh, inpatient services. Well, because they're training in psychiatry. The doctors who are looking after the patients are training in psychiatry, and I think that the further you go from medical school, the more you forget about the general medical stuff and the more you learn about the specialist stuff. So you kind of, unless you're doing something all the time, you're not as confident. So they lose confidence, but the thing about having us as GPs there is that they can come to us and ask questions, and then we can reassure them that they do know what they're doing. So it is upskilling and maintaining skills in not only the registrars but the psychiatrists as well, because they sometimes feel loss of confidence, and we can say, yes, you can actually do that, or you've got the right idea, so it is good.
And just never forget the pain of a rash. Question, the pain of a rash, an ignored rash, so much suffering, so much mental health burden when you're carrying a serious skin experience. It's just, we've got to get it right. Hi.
I'm sorry, I just had a question. I hope there's the GPs are getting supervision and support in their role in the clinic as well. That just wasn't mentioned. I mean, you'd be able to do peer supervision, but then something else as well. So.
Yeah. GPs aren't sort of formally required to get supervision like psychiatrists are, but certainly within our organisation we have supervision available, and also GPs do. I think actually this has changed just in the last couple of years with the new continuing medical education, that it is kind of fitted into our ongoing stuff that we need to do. So yes, we do it, and I do it on multiple fronts.
We can't hear you without the mic, so I might get you to follow up afterwards if that's all right. Quick question here.
I haven't heard anything about intersectionality and who's responsible for uncovering the different impacts from people's intersections in this process, if you're talking about a holistic healthcare system.
Thank you. Do you want clarification?
Maybe, yes.
Yeah,
sorry.
well, the impacts of being LGBTQI, impacts of being Indigenous, hello.
I think that's something that has come up within, I think it's come up as a small theme within the research so far, is that it would be nice to have a GP who specialises in that. But I guess I feel as though we are very broadly mental health aware, and I've certainly had patients from the LGBT community that I'm caring for within that role. So it's it's not like.
Can't hear you if you're not on mic. Sorry, I'm going to have to keep it moving. I'm going to have to keep it moving. Sorry.
Yeah. Let's talk about this after.
Yeah, absolutely, because it is a vital thing, and it's also as much about anything as about reading as much as you can to climb inside the shoes of your patients.
Yeah, and involving specialists whenever there's anything we're not sure of as well.
I'll take one more question very quickly.
Amazing work that you guys are doing in there. I think it's fantastic, and I know that you mentioned there's some other work happening with GPs being integrated. I think our silent rehab services had a GP come in, which is fantastic. I guess my question is, obviously you're engaging with people that maybe aren't within your service and providing that GP care. When people are, I guess, discharged or leave the care of your service, how does that GP follow up? Because obviously they've established a really fantastic therapeutic rapport with you. How does that then continue once they've left your service and are receiving that care ongoing in the community?
Yeah.
Quick
so,
response.
Yeah, so with any of our patients, then we're always thinking about discharge planning and finding a GP in the community that somebody is handed over to. So yeah, that's always a part of it. But I could talk for hours about all of this.
So two statements from both of you about advice for setting up such a service. For people who are interested in setting up such a service in their area or having the conversation.
I think you've got to approach the local health service about whether this is a feasible thing, and we're really hopeful that having this research published will actually be something that other services can say, all right, here's something that we can go to government and ask for funding for having GPs embedded in the service.
Great. And would you like to add one? About setting up such a service, what would you recommend?
Yeah, so I think, local resources and organisational support is definitely the biggest thing.
Okay.
So we are very lucky to have the local Equally Well committee, and I think that is the very primary step that we got support. And our senior nurse Harrison is sitting here today. If you're also interested in such model, he can be approached to give you more information.
Great. Thank you so much, Simone and Regina.